All right, that should be going. Instagram. Boom. There we go.
All right.
Are you live on yours, Mimi?
I think so. I never know for sure, but I think so.
You never can tell sometimes. Well, you should be able to see a little preview on the Instagram part.
Oh, you know what? No, I think I have to go live.
Yeah, you got to hit go live on your side.
Oh, okay. Now we're live.
Excellent. All right. Hello,
Yes.
everyone. It's Dr. VanderWel, Dr. Tan, and we are doing a multi-platform streaming live question and answer discussing all things weight loss. So thank you very much if you're tuning in. And I say, let's get going into it.
Let's get going.
So this is our practice. This is Aviva. We've been doing bariatric surgery for almost 20 years now. Got a great team of people. You'll love to meet them. They do a great job what they do. They love taking care of people that are struggling with their weight. And yeah, there's a lot of really good stuff, really good options out there for making progress now. So we are going to discuss that stuff today. Let's start with the big picture first, though. Why is obesity so hard? So I like to kind of take the 30,000-foot view here, which is our bodies are not made to live in the 21st century. They are made to survive hardship and scarcity, not the comfort and abundance that we live in. Think about like just 100 years ago, especially 200 years ago, living conditions, the buildings that you lived in and worked in, way less comfortable, not climate controlled, had to chop your own wood to warm them. The food that we got, the work that we did was way more difficult. The ways that we transported and the types of food and the ways we stored it, everything there was much more challenging, and it's now just a setup for being able to struggle to maintain your weight. So what are the tools that we got? Dr. Tan, do you want to get us started here?
Yes, yeah. And to go off of your point, I think listening to your seminars has been like so eye-opening for me and thinking about this in a different way, And it's like we've upgraded so many things in our lives to get us into the 21st century. We have iPhones now, we have like all these things, these cars, whatever, airplanes. And it's like, why have we not also upgraded our stomachs? Like we can upgrade our stomachs with surgery. We can upgrade our
21st century stomach. Yep.
Our hormonal systems with medications. Like, why haven't we upgraded to 2.0 yet? We should. So that's awesome. So let's talk about the tools that we have. We'll start with behavioral or like lifestyle modifications, which is the kind of tried, maybe not so true strategy when it comes to weight loss. And this is diet and exercise. These are kind of the keystones to weight loss. And by itself, it is not going to be the most effective means of weight loss. This is why obesity and being overweight is such a large problem in our society. And it's becoming more and more of a problem. It's because we have used this for so long, and it's just not a very effective tool. Typically, you can expect to lose about 5% of your total body weight with exercise and diet, which means that if you're about 200 pounds now, you can expect to lose, again, about 10 pounds on average with this strategy. That said, I think it's still incredibly important to always be mindful of diet in particular. Like everything that we talk about moving forward, it is not going to be as effective if the diet piece isn't there. It's totally foundational. There's nothing, you can't get very far without either one of these pieces kind of being in place. So not effective alone, but still important.
Absolutely. Biggest Loser. I remember this show. Almost all these people go on to gain their weight back, and almost all of them go on to get surgery. Yeah. Done surgery on Biggest Loser contestants.
Yeah.
So this gets a grumpy face emoji, frustration, disappointment. All right, weight loss tools. So I'll start by talking about the weight loss medications. So this is the legacy medications, for lack of a better term, like phentermine, topiramate, naltrexone, things that we've been using, and then any number of the brand name derivatives of sort of many of these things. And these medications have been on the market for a long time now. We've been using them for in some cases decades, with good effect. they take the edge off. They do make some improvements. They make a little bit of progress, but it is something that it's like, we never promise people the moon with these things. It's like, hey, this is a little bit of help. This can help. I remember a lot of people actually say like, I maybe lose a little bit of weight, but what it does is help me get on with my life. It helps me struggle less with, thinking about food, and kind of turns down that volume on the food noise. But from a weight loss standpoint, if you lose 10% of your body weight with medical weight loss, that's a pretty strong result. That's above average. So they are good. They have their place. But that about sums it up. All right. GLP-1s. These are the sexy ones everyone wants to talk about nowadays.
Yeah, weight loss, the injection medications. I think that like I was reading a paper over the weekend, and it brought up this like interesting idea when it comes to these weight loss medications, and that's like non-response rate. Like how many people just do not respond to certain medications. And with a lot of these oral medications, we're looking at like a 50% non-response rate, which is pretty high. Like 50% of people just don't lose weight with those meds. And what's really cool about these injection medications is that rate is so much lower. It's like looking like 10, maybe into like the low teens %. So a lot more people are actually responding to these medications. And so these injection medications, these are the newer medications. These are the medications that you're hearing about all over the news. It's the Ozempics, the Wegovy's, all of these things. And the reason why they're getting so much press and media attention is because they are the most effective weight loss medications that have come to a market to date. We're looking at anywhere between 15 to 20% weight loss with these medications. They are generally speaking going to work both on your brain and kind of tamping down some of that head hunger response. It also works on your stomach, and it just reduces how quickly food moves through your GI system, and so that you feel fuller for longer, and you feel fuller faster. And so really, really great medications. Now, downsides of the medications is that they do all tend to have some side effect profiles that some patients do deal with. And that's just true for all medications, that you do sometimes have to worry about side effects. And so there are some patients who just can't tolerate it. Some patients just need an additional medication or something to help with things. I see a question that, is this 15 to 20% excess weight? So this is total body weight loss. So again, if you're like if you're about 200 pounds now, we would expect that you would lose about 35 to 40 pounds on average with one of these medications. That's a great question, because excess weight versus total body weight loss is sometimes a very confusing thing that gets thrown around and interchangeably, which it should not be. But the other downside, I would say, that we often right now see with these medications is an access issue. And so there's shortages all over. And then right now, a lot of insurance companies are not covering these medications, and they're extremely expensive if you are paying for them purely out of pocket. And then another question that I see on here is, I'd love to hear your thoughts on coming off of injections. And that is another great question that I think goes into one of the other downsides of these medications, is that right now, when I start these medications, the intention is that you're likely going to need this medication long term. What we find is that as we start coming off of these medications, at least what the data is showing, is that most people are going to regain weight. There is a percentage of patients who do not regain weight, though. And so I do think it's always a worthy goal to try to wean off of these medications. And I think in that sense, some data is showing that we just have to come off slowly, and you want to do it in a way that's monitored, so that we can watch you, get you back on the medication if you do start regaining weight.
I think what we're also seeing in our medical weight loss program is people that have had surgery have a much higher success rate of weaning off of the medications. I'd say they have more. It was surgery plus these, especially the GLP-1s, plus medical weight loss in general, but especially the GLP-1s has been very complementary. And we can use less doses of the medication and and I think have a little bit more chance of weaning people, or if not completely weaning people, they kind of hold some booster doses. And so they are able to like, okay, I'm struggling right now. I'm going to just take this for a little bit and then, kind of take a holiday.
Yeah.
It's an interesting field right now. It's a very interesting time. So
can be super excited. Yeah. I think these medications it's awesome that we have these, and just like being able to use them with other things is just amazing too. So it's just such
I think the data is getting more clear and clear. My guess is that in 5 years time, any bariatric procedure that we do will also complement it with medical therapy, like at the same time, just the same way we treat cancer. Like if you have breast cancer or if you have colon cancer, like you get surgery and almost always you get chemotherapy and sometimes radiation therapy too. Like they just see that even no matter what your response, we don't wait for your response to fail. We kind of say, hey, this is the best way to get we're trying to get to this result. And the best way for the most amount of people to get their result is this plus this plus this, whatever.
Yeah. I mean, it just plays into like obesity. I think we're finally starting to see it as a chronic disease.
Yeah.
We're finally starting to see it actually like as an actual disease like cancer, where we have to be aggressive and treat it consistently and often for a long period of time. So,
So cool. All right. Well, thank you everyone for tuning in so far that's logged in. If you have any questions or comments, you're always welcome to put them into the chats. It's always fun to have some interaction. So, yay. All right, next thing. Now we're going to cross out of the medications part into the procedure world. And this is where we have people, this is where we're going to talk about the endoscopic sleeve gastroplasty or the endo sleeve or the ESG. And this is a really cool new tool. So new is relative. We've in our practice, actually, I've been doing this for 4 years now, hundreds and hundreds of patients. It's been done 10 years now in the broader world. And it's a really cool tool. What it is it's a suturing device that places sutures and then it goes down through your mouth. And then from the inside takes your stomach, which is this big bag, and it takes bites of it and it crumples it down and it collapses it so that your stomach gets a lot smaller. When your stomach is smaller, that inside lining, so your stomach, I describe it as the conductor of the complex hormonal symphony that controls your body's weight thermostat, its metabolism, its blood sugar, and to some extent, even blood pressure. And when you change that stomach, particularly, it seems that reducing the amount of mucosa, the surface area that's in contact with food, when you crumple that thing down and make it much smaller, number one, you can't eat as much food, but number two, hormonally, it gives you this edge. Like it just changes that song that's going on inside of your body that makes it much more feasible to be successful in eating a healthy diet in small portions. And also, which is cool. It's a really, really cool tool in that regard. So I think having that is a fantastic way to really get the edge going and make some great progress. The cool thing about the endoscopic sleeve is that nothing is taken out. Nothing is removed of your stomach. It just crumples down into a smaller shape. There's no incisions. There's a number of celebrities that have gotten ESGs. They have people from every single walks of life have had endoscopic sleeves. It's a really cool tool. And especially if you're like, man, I just need something. I know I want to have, some of the best results I can from a weight loss standpoint, and I just don't think surgery is quite for me. The ESG is a fantastic tool. It definitely, this is a suture pattern. So this kind of shows you how it kind of crumples up. But it's a really cool tool. It's a really cool tool. We've been doing it in our practice for a while now and been happy with it So.
Great. Can I throw a question at you?
Yeah.
About ESG from our YouTube, actually. With the ESG, what happens to the part of the stomach that is sewn up? Could that tissue not get blood and die? Could food ever get trapped in the pouch? All really good questions.
All very good questions. What happens? So your stomach, right? It gets this big bag, and then you have this suture that kind of goes along the outside, and then it crumples that all down into the wall on that side. So it doesn't die. What it seems to happen is the part, just like with anything in your body, the part that's kind of secluded or crumpled down or not being used atrophies. So all the cell linings in there atrophy. They don't die and they don't go away completely. They just atrophy. Your stomach isn't able to expand. And so it just seems to get smaller. There are probably little pouches in there, and that's a really good question. Like, is there food that gets stuck in there? It doesn't seem so. Like, we seems that whatever little pockets are in there, there's enough stomach muscles or something to like expel it or get it out of there. I've yet to see that be a problem in any patients of my own, or heard of it even be a problem in patients that are out there.
Yeah.
So
That's so funny, because that's probably one of the more common questions I hear about the ESG, and I'm always like, I don't think it happens. I've never heard of it happening. But
it's just strange how this all works. Like how it I don't really understand. We don't understand a lot of things that are interesting about the ESG.
Wild.
Like, the biggest mystery about the ESG is actually how people's heartburn almost always gets better and it almost never gets worse. Because that's probably, the laparoscopic sleeve is a fantastic tool, but its biggest downside is the heartburn that can happen to, it's not everybody, but it's a noticeable, it's a real number of the population that gets an ESG will have a little bit of worsening heartburn. But that almost never happens with the endoscopic sleeve. And we're still in mystery about why. Even all of us who have pretty different techniques, pretty different suture patterns. I'm pretty aggressive with my ESG. I close a lot of it, a lot of the fundus, which a lot of people stay away from. All of us have the same, improvements in heartburn. So
stomach is a magical organ.
The stomach really is. It is a wild organ. It is a wild organ. Great. All right, we got a question from Turin. I hope I said that right. What are its advantages over other surgical techniques? Great question, Turin. So the endoscopic sleeve is the biggest advantage is that it's done endoscopically. There's no incisions. You're not actually going in through the abdominal wall at all. You're actually going in from the inside, and you're sculpting the stomach from the inside. I get a lot of patients referred to me from other surgeons who these patients have a lot of scar tissue or something like that inside of their abdomen, where it's actually dangerous. It's because it's hard to sort things out and things are all stuck together. It's dangerous for them to go in and do other surgeries of other sorts. And so that's where the ESG is just is an absolute rock star, is that where if you have a dangerous, a tricky abdomen to get into, but that's not that many people. Where the other advantage versus the surgical techniques is that it's not surgery. Its complication rate is very low. Knock on wood, our complication rate for our laparoscopic sleeves is also really low, but the ESG is even lower. Like, we're talking like less than 0.5% low. And those issues that do pop up, like we can manage those. Like, those are manageable. The surgical techniques, there's nothing's removed, nothing's taken out, which really appeals to a lot of people. I tell people, because you're not removing that, it's probably not quite as strong of a tool to help you lose weight. Like we'll see in a second, the laparoscopic sleeve generally loses a little bit more weight than the endoscopic sleeve for most comers on average. But the ESG is, it doesn't remove anything. And that really appeals to a lot of people. There's no incisions. It's people think of it as like it's technically reversible, though very difficult to do. So that's mostly what it's, there's some great advantages there. So,
yeah. I've started calling it the incisionless sleeve. Because when you start talking about, comparing it to the laparoscopic sleeve and whatnot, people get kind of confused. So I've been calling it the incisionless. I kind of feel like, it's the main draw of it in some ways. So
I like it. Yeah, because endoscopic, people don't know what endoscopic versus laparoscopic is.
Yeah, and some people don't do their sleeves laparoscopically, so it's all very confusing.
Yeah, cool. I hope that answered your question, Turin. If it didn't, if you have others, please send them in. Thank you for submitting that. All right, Dr. Tan, laparoscopic bariatric surgery.
Laparoscopic bariatric surgery.
Deets.
Yeah, our favorite topic. So bariatric surgery, this is going to be the gold standard. It is the best tool when it comes to weight loss. And when I say best, I mean this is on average what you are going to lose the most weight from. And also best in terms of just overall health benefits that you will get from bariatric surgery. And I think in a lot of ways, this is really the magic of bariatric surgery, is all of the amazing metabolic benefits that you end up getting with surgery that are separate from the weight loss, and that you actually see even without the weight loss happening initially. We're transitioning away from calling ourselves bariatric surgeons or weight loss surgeons, because it really is not only about the weight loss. It's about all of the metabolic benefits that you see with this surgery. But going back to weight loss, you are going to see about 25 to 40% on average weight loss with these surgeries. And this is, again, total body weight loss. So a percentage of your current weight when you go into surgery. The two main surgeries that we offer are going to be the sleeve gastrectomy and the Roux-en-Y gastric bypass. We do this laparoscopically, meaning we make small incisions like this picture shows. And then we do the entire surgery through those little incisions. A lot of these surgeries are going to be same day, meaning we do the surgery and then you go home the same day of surgery, and you do not need a hospital stay afterwards. Really nice to be able to sleep in your own bed for a lot of our patients. And the sleeve, what we're doing is we're taking out most of your stomach. We leave you with this thin banana-shaped stomach afterwards. The gastric bypass, a little bit more complicated, but we turn your stomach into a small egg-sized pouch. And then we connect a portion of small intestine and we bypass most of your stomach in the first 100 centimeters of your small intestine. So you end up with like a Y-shape anatomy. One of the limbs sees food, one of the limbs does not see food. And so there's a malabsorptive part of the procedure as well.
Sorry, I thought I had showed a little picture of the gastric bypass in here, but
it's a small. I bet most people are looking at it.
Yeah, I feel like what? Yeah. In the best of circumstances, you're kind of like, what's going on here?
What's happening? The bypass is one of the most confusing, I think, procedures to try to explain, like conceptually. I think it's just like it's a difficult, even with the picture, it's hard. So, but anyways, great procedures, most effective for weight loss. That is the highlight, I would say.
Yeah, great tools.
Yeah.
All right. So thus concludes the little presentation part. If you have any questions, you'd like to submit about any of these issues, happy to address them. There was a couple that were previously submitted. I can see if I can find those. All right. Do you have to do a liquid diet? Good question. If you do a procedure. So our practice, we have tried to streamline our care for all of our procedures. So endoscopic sleeve, laparoscopic sleeve, gastric bypass, all of them have a very similar preparation phase and recovery phase diet progression. We don't do a liquid diet in the sense of like a pre-op liquid diet, like some places do. We just do a pre-op high protein, low carb diet, usually 1,200 calories for women, 1,400 calories for men. And that's usually great for shrinking down your liver, getting some weight loss in that first phase. The other phase that we use a liquid diet though for everything is the week after, 7 to 10 days after any of the surgeries or the procedures. We do a liquid diet, and then usually you progress to a pureed diet after that for a week or two, and then it's soft food and then regular food. So usually you're doing regular textures within 4 to 5 weeks after the procedure. So, good question. That is the one that comes up a lot.
I have a question here. This is a good question from Butterfly in Progress. What do you think about getting a sleeve with a BMI of 32?
Oh, yeah.
You want to start? What are your thoughts?
That's a great question. I am 100% on team low BMI bariatric procedures, 100%. Like we said earlier, I think our stomachs are not made for the 21st century. And if you want a 21st century stomach, then I think we have seen this do so well with people with low BMIs and really help them get back to who they feel like they are and really help them get towards living a better life and just feeling more in control. I just talked to a guy today, low BMI, and interested in an endoscopic sleeve, who was just like, I just feel like I can't, I'm really struggling with my weight. I'm, 45, 50 pounds above where I want to be. And you may not even be that much, but especially if you're a smaller framed woman, particularly, and you're 30, 35 pounds above your normal historic adult weight, like that's a lot. That can be a huge percentage for you. And I think these tools I've seen them help people over and over and over again.
Yeah.
They're tools. They're not cures. They're not magic wands. I really tell people they're not retail therapy for getting, some sort of result. But man, it can be a very effective tool for helping you really get towards the direction that you want to be going. Because it is just like, it's when your stomach's smaller, it's just so much easier to manage your body's relationship with food.
I mean, I think this just gets to like BMI is not one size fits all. Like someone can be at a BMI of 32 and be perfectly happy, feel good, be able to be active, but someone can sit at a BMI of 32 and feel awful and like feel like there's a lot of room for improvement for whatever reason. And I think, as with a lot of things in medicine, you have to look at each individual person. And there are like guidelines and rules when it comes to bariatric surgery and when that's offered, but there has to be flexibility in that. And a lot of people can probably get a lot of improvement in their lives with weight loss at a lower threshold than what we typically recommend or whatever for weight loss surgery. So very personal,
Yep.
Yeah. And then I think there was another question from online that we can talk about. It's from Marvin. Marvin, he weighs 420 pounds and stands at 5'11". He's been dreaming about losing all this weight, but I don't think I have the money for it. How much would it be for a weight loss surgery? It's a little bit about cost.
Yeah, that's
which we can talk about a little bit. Yeah.
No, I think it's really important because that's a part of the real life experience of it too.
Yep.
So, I think bariatric surgery, like any surgery, of course, isn't cheap in the United States. Like there's a lot of things that we do, but from a safety standpoint, it's also really, really valuable. Our program also includes a full year includes the visit. That price includes all the visits ahead of time, and includes at least a full year of visits with your nutritionist, with your surgeon, with our other providers. And that's usually around $20,000, including anesthesia for a laparoscopic sleeve, and around $15,000 for an endoscopic sleeve. Those numbers can seem really expensive until you start like remodeling your house. And you're like, man, I can remodel my body and give myself a tool to remodel my surgery, my stomach, for much cheaper than a bathroom remodel. So I think it's about perspective. And I'd say I have, 99% of patients say this is really one of the best things that they've ever done. And they're really, they're really glad that they did it, and they just wish they'd done it sooner. Mm-hmm. They do it again. They do it again right now. So,
yeah. And I think it's also worth just mentioning to like look into your insurance too, or like have someone do a benefit check for you and see if you would qualify for having your surgery covered by insurance. Unfortunately, we all wish that more insurances were covering these surgeries, but
no, that's actually a great question too. So what do you do if, okay, my insurance doesn't cover weight loss surgery, what do I do next? So, the easiest thing is to look at your self-pay prices, but the problem is that those can be expensive, and it can be expensive. There's no getting around that. The next thing is to say, okay, well, is there another insurance? Is there another policy actually provided by my employer that I could potentially buy that actually covers weight loss surgery? And that's actually pretty common with a lot of big employers around this country, around this state. Is that there are options for plans that have weight loss surgery benefits. So looking at that and saying, okay, have a plan. So when open enrollment comes around, I'm going to sign up with this plan. If you're not sure how to do that, reach out to us in our office and reach out and say, that's just the way it works, and that's the way that we have, our team knows a lot of the different insurers and how they can get stuff covered from their programs. So,
I think just to bring up also, I think like advocacy at this point is also something worth doing if you're interested, and like getting a letter sent to your workplace if they don't provide bariatric benefits, and being like, this is the value of bariatric and like weight management or weight management kind of services, and this is something valuable that our company should provide to employers. I think stuff like that's really important too.
Yeah. And then also sometimes, I do have patients that they're like, you know what, it's too unaffordable to get it out of cash pay. So I'm going to actually, they're like, hey, I'm kind of looking for a change anyway. So they look for changing to an employer that has weight loss surgery benefits. So, if you have questions about that stuff, reach out. Question again from Turin. Can we talk, if we talk about the complications of bariatric surgeries, what should we be more careful about? Good question about that. So yeah, everything that you do in life can have complications and side effects. Yeah, 100%. Bariatric surgery is no different. The things that we worry about are things we worry about with every surgery. So pain, infection, bleeding, blood clots, damage to surrounding structures, any of those could potentially lead to death. Knock on wood, the chance of that happening is extremely, extremely low in our practice. We submit all of our data to the national database. We have really good results. We perform really well above the national averages on all those metrics. So I would say the most feared complications after that whole long intro are a bleed or a leak. That's the ones we really worry about. Is the bleed or a leak, those are the ones you're like, oh man, or blood clot. The way you get through those is, if usually I can tell by just hearing in someone's voice, like if something's, potentially wrong or not. And so you get checked out in the emergency room or something like that. Usually CT scan is going to help us. If you have a bleed, sometimes that's pretty obvious. They're like, oh man, blood pressure's down or something like that. And then we just go we fix it. We fix the problem. And that's the goal, is we got to just figure out what's going on. And then we find a way to fix it and get it going in the right direction. Yeah. Sometimes it takes a little longer to fix some things than than just like one surgery, but the chance of that's really, really low. It's really low. But yeah, these are things that you want to make sure you have, really good help working on, and people that are skilled and experienced, and that can manage the complications that could potentially come from it. So complications in our practice are really, really low. We take a lot of care to make sure that they stay that way, make a lot of care to make sure people get through things safely. But if anything does happen, we get them through. So.
I mean, I think in all that, because he also asked like what we should be careful about. I think like having good communication with your surgeon is really important in all of this. If you're worried, we're worried. And then things to do. I tell in my mind, the most serious complication is a blood clot, because that's like one of the very few things you can actually like maybe die from after the surgery. So a lot of walking, that is like the thing I tell all my patients, like walking to make sure your blood's moving, and that's incredibly important. Okay, I have a question here, or I have a couple questions here. The Nicole Chronicles, she asked, at what point can you go from chewable vitamins post-surgery to capsule pills? I don't know what your take on it is, but I usually tell my patients whenever you can tolerate swallowing a pill or a capsule with a small sip of water, then I'm okay with you taking that. For vitamins, I just want to make sure that is like a program approved vitamin, just because our bariatric patients need a stronger vitamin typically than your standard vitamins that you get at the drugstore.
Yeah.
Is that pretty much how you feel?
From a vitamin standpoint, yeah, I lean on my dietitians. They're really good with their vitamins. They're like vitamin whisperer pros. I feel like they're so good with that stuff. I don't know, maybe I need to up my vitamin game. But I usually tell people too to wait at least a week before the vitamins, because especially the bariatric grade vitamins, they're strong, and they're like, whoa, there's some weird sensations going on when I got all these powerful things inside, that I just took now. So that's where I think going on the puree is having something a little bit more substantial in your stomach. It's good. So I don't really worry about pills versus capsules too much, honestly, the beginning phase. Like, it's almost never a problem. So even like metformin pills that are pretty big, and we're like, that'd be fine.
I'm usually like, if you can swallow it, that's okay. That's okay.
If you can swallow it, if you can get it down, you're gonna be all right.
Your stomach can handle it. And then I have one other question on here. What do you think about the set point theory? I think this is regarding metabolism and weight.
It's been pretty interesting. I don't know if you guys, I don't know how much time you spend in podcasts and whatnot, but it's been popping up a bunch lately, the set point theory. So that is where like your body has this weight range. I kind of call it my thermostat theory. of range, where your body has this range of what it's acceptable in. And then when it gets out of that range, it's like, whoa, what are you doing? This is not okay. I'm pretty hardcore on team set point theory, on team thermostat theory, whatever it is. Because I think almost everyone I talk to, people in my own life, people myself, feel like I would have a hard time gaining 50 pounds. Like it would be really a challenge for me to gain 50 to 75 pounds. It's really a challenge for me to lose 10 pounds. And because you have this range that your body wants to live in. And as soon as you lose a little bit of weight, your body's like, oh no, this is not good. I'm going to die. You're going to kill us. We're not going to survive the winter. Go eat some food. Like go find some food. That's where, for me, what I see in the thermostat theory in this stuff, and particularly doing bariatric surgery and endoscopic sleeves particularly are very interesting. When you just all of a sudden go from normal stomach to smaller stomach, all of a sudden your body, when it goes into a calorie deficit, instead of getting on the loudspeaker and being like, go get some food, we're gonna die, red alert, go get that freaking right now, go raid the fridge right now. All of a sudden your body says, okay, we're cool, just go to the storage unit. We have all this stuff supplied and packed up in the strategic petroleum reserve back here. Let's just go pull that stuff out of storage. And all of a sudden, people come back after they've been on, a significant very significant calorie deficit, like well under sub 1,000 calories for a month. And they're like, what's weird is that this is okay. And I feel better than I have in a long time. They get tired, they run out of gas because your body can only move energy from the storage unit to where you need to so quickly, because the biochemical like proteins and enzymes and stuff like that to process the fat into energy, it's not built up yet. And so, but the switch has been turned on, and all of a sudden the highway has been opened they've taken the gates away and they've directed the traffic from storage unit to all the places where it needs to go in your body. I think it's really interesting. I'm big on set point theory. How about you, Mimi?
I agree. I agree with it just because it is what we see in practice, right? Mm-hmm. Like most people cannot lose a significant amount of weight and keep it off. And I think that's just proof of theory. Like it's you fight your body and where your body is living at. And so
and as your body this is that phase 2 of, like, I remember this came up too when I was hearing someone talk about their set point theory thing in a podcast this week. And it's that as your body gains weight, it doesn't really it rarely ever recalibrates to like, oh yeah, we need to go and lose a bunch of weight. Some people it does. And those are the people that like can lose a significant amount of weight and they're like, oh yeah, just keep it off. Just doing what I'm supposed to be doing. But a lot of people, they're really, really struggling with doing what they're supposed to be doing, but they just cannot seem to make progress because their body's like, no, we need this stuff now. We are gonna die. We're not gonna survive the winter. We're not gonna survive the famine, because that's what your body really thinks like 200 years ago, like where it's like, food is scarce, life is hard, winter's coming.
Yeah, I mean, right, like that totally makes sense from an evolutionary standpoint, right? But the thing is we've moved past that point in our evolution, and we have to upgrade.
Yep.
Time to upgrade.
All right, we got some more questions here. Mazid from Kazakhstan says, hello, bariatric surgery in Kazakhstan is approximately $5,000. Yeah. Dude, if I can't even get my equipment for $5,000 in the United States. So, Turin, if an obesity-related sleeve surgery were planned for you today, which surgical technique would you choose? If an obesity-related sleeve surgery were planned for you today, which surgical technique would you choose? So I think the question is, I have a sleeve planned. Should I do an ESG? Is that the question? Maybe.
Or maybe like laparoscopic versus robotic.
Okay.
Or is he saying what we would do for ourselves if we needed to? I don't know.
So I would say that I do. If you're willing to do surgery, do surgery. Laparoscopic sleeve, it's a fantastic tool. It's a really good tool. It has good results. It has a very low complication profile, and it has good durability. If you're like, I'm a little hesitant about surgery for where I am in my life right now and what I'm trying to do the endoscopic sleeve. Like, if you're like, I don't think I'm at surgery, I don't think I'm in team surgery, go do an endoscopic sleeve. Hands down, no questions asked. It's a great tool. Yeah, next best thing. So
Yeah.
I hope that answers your question. If that does, so these are big questions. They're personal questions.
It's
Sorry, I got
hugely
some more.
personal. Yeah.
Yeah, got some more questions. Ali Nova official doctor. I want to start semaglutide, but I wasn't eligible because my BMI is not in the overweight range. If I go to you, could you still send me a treatment with semaglutide? So, Ali Nova official. So I would say we are happy to see you and talk about these things. I think our program is not, BMI is a number, and it does not encapsulate at what every person experiences and the differences that are out there in people's lives. We have people that, are struggling with their weight at any BMI that feel like they're significantly above their set point. And there's tools that could potentially benefit them. And I think that's a cool thing. I think having dedicated my life essentially to people that are struggling with their weight is so much more than about a number and how much weight you have to lose. It's about so many bigger things in your mind, right? And like the struggling with your diet, thinking about food all the time, and all these things that come with it. And I think if there's tools like medication that can help you with that and help you just like honestly get on with your life and live a great life, and also be healthy and be happy and be really proud of, not, and being in control of like your body's relationship with food. I mean, I'm in the camp of like, why would I not do that? Like I am, if we have tools that are low risk, low side, low or very manageable side effects that are going to help people make their lives better. I don't know. What's the question here? Like, of course. So it's always more complicated than that. Maybe I'm oversimplifying, but that is, reach out, Ali. Chris Dahl, 1992. Chris, some people say that the money they save on food pays for their surgery within the first year. Actually, I hear that all the time. So, yeah. And the thing that's cool about these journeys, the journey of this stuff, is that, these tools, they just help you. This is not a complicated journey. It's not a complicated journey. It's just really hard. It's really hard to lose weight, but it's not complicated. It is eating healthy food in smaller portions, getting some activity, and managing your stress and getting some sleep. But the problem is doing that is just like, that's a lifelong journey. And when things just feel like you're really stacked, the deck is stacked against you, these tools can help you a lot. So. All right, Tern. Thank you for spending time on my questions. Good night. Good night, Tern. Yeah, I guess you're somewhere farther away, Tern. Yeah, no, I think, hope you sleep well, Tern, and happy to answer questions. All right.
We wrap up?
I think that's all I got.
Yeah.
So, we try to do these seminars, with some regularity. We're going to try to get back into it more frequently. And if you have topics that you would like us to kind of address and hit on a bigger scale, or kind of in a different, we do the weight loss treatment stuff, fairly frequently. But I think it'd be great to talk about maybe some revision sometime, or like the mindset piece, any number of different things. If you have topics, put them in the comment section, send them in our DMs, whatever it is. We'll try to, we'd love to just kind of address what are issues that people want to talk about. So, all right, everybody. Well, thank you so much and have a great day.
Yeah. Thanks for signing in, everyone.
Yep.